A nossa reunião aqui em português, tá? Começando agora com a apresentação do artigo pela Aline. Na sequência, às 9 horas, a gente vai ter a participação, a entrada do pessoal da Universidade de Nebraska, nosso segundo encontro, e nosso tema de hoje será em altas ametropias, até quanto a gente consegue ir e quando a gente indica um procedimento ceratorrefrativo ou a gente indica implante de lentes ou, enfim, extração, né, também do cristalino. Bom, vamos lá. Aline, por favor, você pode começar em português mesmo, tá?
Tá. Bom dia, meu nome é Aline, eu sou fellow desse ano, vou apresentar o artigo de hoje. O artigo fala sobre resultados com 6 meses, né, de pós-operatório, depois de correção de alta hipermetropia, tá? Usando LASIK com uma zona de ablação maior, tá? Ele foi publicado na Cornea no ano passado, e 2 dos autores, eles são empregados da Fringe Eye Tech Solutions, então temos que lembrar disso, tá? Como uma breve introdução, a gente sabe, né, que para ablações hipermetrópicas, a gente precisa ter cuidado na zona óptica, na zona de transição e no que seria a ceratometria final, e que para correções maiores tem uma diminuição tanto da segurança, da previsibilidade, da estabilidade refracional e, portanto, da qualidade visual no pós, né? E aí o objetivo desse estudo foi avaliar, tá, esses resultados refrativos e visuais, tá, com 6 meses de pós-operatório de LASIK, para corrigindo hipermetropias acima de 5 dioptrias, usando uma zona de ablação total acima de 9 milímetros, com perfis neutros de aberração, tá? Então, foi um artigo que, na verdade, foi uma série de casos, né, de março de 2014 a abril de 2018, foram 147 olhos de 77 pacientes, com pelo menos 5 dioptrias esféricas, né. No pré-operatório foi visto a visão não corrigida, corrigida, o equivalente esférico, o astigmatismo. No intraoperatório foi usado o Schwinn Amaris 750, tá? O limite do laser era até 8 dioptrias esféricas e 7 dioptrias cilíndricas. Foi feito o LASIK com microcerátomo de memória, tá? Usaram perfis neutros de aberração, e a centralização foi de 3/4 do vértice, né, do ápice da córnea em relação ao centro da pupila. Além disso, eles selecionaram anéis de sucção para que conseguisse o maior diâmetro de flap possível, que seria maior que 9,5, tá? Se levantando o flap, a zona de ablação total fosse maior que o estroma, eles reduziam a zona óptica, e para 24 olhos que já eram presbitas, eles hipercorrigiram em 1,25, e para 11 olhos que superavam o limite do laser de correção, eles foram hipocorrigidos em 1,5. E no pós-operatório, os mesmos exames do pré-operatório. Então, a visão não corrigida, o equivalente esférico e o astigmatismo. Então, para resultado, em relação a esses dados do pré-operatório, queria chamar a atenção aqui o esférico máximo, né, que foi incluído no grupo, né, de 9,5, tá? Com 5,75 de cilindro, e a ceratometria, o máximo já era, assim, uma ceratometria mais importante, né? E em relação aos dados do tratamento, também chamar a atenção aqui que o máximo foi de 8 dioptrias, então fala a favor do que ele já tinha falado antes de hipocorrigir por conta do laser, tá? Além disso, eu queria mostrar aqui o mínimo da zona óptica, da zona total e da localização da máxima de profundidade, que a zona óptica foi de pelo menos 6,7, a zona total foi de 9, e a localização foi de 7,2. Então, aqui a gente já consegue perceber que a ablação, ela supera o tamanho da zona óptica, então, muito provavelmente, pega a zona de transição. Como a gente consegue ver aqui, no que seria o jeito, né, que o Amaris, ele abla, então, a gente consegue ver que o pico de ablação é um pouco depois da zona óptica. Em relação aos dados do pós-operatório, o que eu queria chamar a atenção, não só a ceratometria, mas esse inconveniente esférico de menos 2,25, muito provavelmente era por conta daqueles pacientes que foram hipercorrigidos por serem presbitas. A cerato média já era de 47, 48 dioptrias, que chegava a 52, 53 dioptrias na ceratometria máxima, e teve pelo menos um paciente que ficou com uma visão não corrigida de 0,52, que seria mais ou menos entre 20/60 e 20/70, então, para esse paciente não foi um resultado bom, né? Em relação à acuidade visual cumulativa, a gente vê aqui que 60% dos pacientes conseguiram uma visão de 20/20 no pós-operatório, tá? E 97% dos pacientes conseguiram uma visão de 20/40. Então, isso teoricamente cumpre aqueles critérios do FDA, tá? Para eficácia do tratamento, tá? Em relação à acurácia do equivalente esférico para o alvo, né, intencionado, a gente consegue ver aqui que 66% dos pacientes ficaram entre menos meio e mais meio, tá? E que 86% ficaram entre menos 1 e mais 1, tá? E também bate com aqueles critérios de previsibilidade que o FDA ele indica, né? Em relação à diferença entre a visão não corrigida pós-operatória e a corrigida pré-operatória, a gente consegue ver aqui que, mesmo tendo 67% de pacientes que mantiveram a visão ou ficaram melhores, tem 33% aqui que pioraram, né? Então, já é um número significativo, tá? Por mais que esse gráfico não é o gráfico preconizado para avaliar segurança, mas é o melhor gráfico para a gente mostrar essa porcentagem de pacientes aqui, tá? Em relação ao equivalente esférico esperado e o atingido, a gente consegue ver que é um gráfico mais disperso, né, tá? Os pontos estão mais dispersos no gráfico, tá? E se a gente for pegar ametropias maiores, por exemplo, essa daqui de 8 dioptrias, tiveram uma parcela de pacientes que ficaram hipocorrigidos, né? Então, o coeficiente de determinação não foi tão confiável assim. Em relação à alteração na ceratometria, a gente vê também que os pontos estão mais dispersos no gráfico, né? E que uma parcela importante de pacientes ficou com uma correlação menor do que o que seria a correlação linear, né? Então, como conclusão, os autores concluíram que usar zonas de ablações maiores com esse perfil de aberração neutro tem uma boa eficiência, segurança, né, e previsibilidade, né? Mas queria abrir aqui para discussão, lembrando assim que ele não fez um grupo controle, e ainda assim, no mesmo grupo, ele colocou pacientes que não foram corrigidos de uma maneira certa, né, foram hipocorrigidos, foram hipercorrigidos, tudo no mesmo grupo, então esses dados foram diluídos no resultado, né. O uso de microcerátomo também tende a ter uma maior regressão que o fento, mas que essa regressão pode não ter aparecido por conta do follow-up que foi pequeno, né, foi de 6 meses somente. E ainda assim ele não avaliou, né, a aberração induzida pelo tratamento, tá? Mas fica aqui a discussão, queria abrir para discussão o que seria, né, a importância da zona ótica maior e menor para esse tipo de ablação, qual que é a preferência da centralização, se em relação à pupila ou ao ápice da córnea, o que vocês acham do máximo da ablação, né, ultrapassando a zona ótica, e a gente sabe que não é um resultado muito bom desse tratamento, mas como que seria em relação aos outros tratamentos para esses pacientes, né? Ou fazer uma faco refrativa, ou talvez uma lente fásica, como que seria a comparação com esses tipos de tratamento? E era isso que eu tinha que mostrar, gente. Obrigada.
Bom, obrigado, Aline. Bom, queria pedir aí comentários, a gente ainda tem um tempinho antes de começarmos aqui a reunião com o pessoal de Nebraska. E aí, vocês acham que faz sentido? Acho que não é um estudo assim tão forte, né, do ponto de vista metodológico, mas que traz aí algumas informações. Alguém tem experiência nesse tipo de tratamento acima de 5,5 dioptrias hipermetrópicas? Eu gostaria de comentar.
Deixa eu fazer uma pergunta mais, talvez boba, mas que os tratamentos hipermetrópicos são sempre pouco confiáveis no sentido de progressão de grau, né? O surto miópico ele mantém, e o hipermetrópico geralmente se regride, né? A taxa de regressão é muito maior. Qual que é a razão disso?
Oi, pessoal. Eu queria fazer um comentário sobre o paper.
Opa, claro,
O Wallace. Eu achei até interessante. Assim, eu tenho vários casos de pacientes com hipermetropias mais altas. O que me chamou a atenção foi a cerotometria pré, que a gente sabe que na miopia, falando para os fellows, na miopia a gente aplana, na hipermetropia de curvas, e felizmente os míopes geralmente têm córneas mais curvas e os hipermétropes têm córneas mais planas. Então a gente tem uma gama maior de tratamentos exatamente por isso. Agora, tratar mais 5, mais 6, mais 7 numa córnea de 47, isso que não é legal, mas normalmente esses pacientes têm 40, 39, 41, e aí sim vai muito bem. Tem vários pacientes com altas ametropias, pacientes jovens que não têm indicação nenhuma de fácula refrativa, não tem ângulo oclusível, câmaras anteriores normais, que têm excelentes resultados refracionais e inclusive estáveis, com muitos anos de pós-operatório, com de acompanhamento, e que tem ótimos resultados.
Obrigado, Fabinho. Alguém mais gostaria de comentar? Estou vendo que já temos presenças aqui internacionais, então eu vou já trocar. Então, assim, para o pessoal que está nos assistindo em português, vamos avisando, né? Vamos agora mudar para o inglês, devido à presença dos nossos convidados internacionais. So, welcome, good morning, everyone, to the Surgical Optics Weekly meeting from UNIFESP in collaboration with the University of Nebraska Medical Center. I'd like to thank for your attendance and for your participation. So today we are going to present some challenging cases in refractive surgeries related to high ametropias, and we'll have the participation and as presenters of Dr. Vinícius de Stefano, which is a former resident and fellow here, and now he's starting his career in the US, and also Dr. Ibraim Viana, that is also a former resident and fellow from UNIFESP, and which has been recently in the US as well. And of course, I'd like to thank enormously Dr. Ronald Krueger, which has agreed to participate, and this is already our second meeting, and I hope this is going to be recurrent, as this is a great opportunity to exchange knowledge between our universities. And once again, thank you very, very much, Dr. Ronald Krueger and the University of Nebraska. So Vinicius, if you'd like to say some words, and also if you would like to start case presentations.
Bom dia a todos. Good morning, everyone. Thanks for having us. It's a pleasure always to talk with my always, I was going to say previous university, but it will always be my university as well. So good seeing everyone again. And so I will start this presentation. Let me share my screen here with you guys. Well, Dr. Krueger, as Taguchi said, he's our chairman here right now, and former physician and director of the refractive clinic division at the Cleveland Clinic, refractive surgery division, at the Cleveland Clinic. So highly experienced refractive surgeon. And I'm going to present 3 cases in how we approach them a little bit differently in each case of high myopes. And the idea behind those cases is some unusual approaches and some, and on the other hand, sometimes a very common thing that we face, and try to show how we make those decisions and how we can best address the patient's needs. So I have no disclosures. Dr. Krueger is a consultant for Ophthalmology. And just since I'm talking to my university, this is our resident class from 2014. And of course, Ibraim here is the is the other presenter today, and we have very good people that came out of this class. And just so you know, and this is a full disclosure here, I'm still waiting for Ibraim to return this tie to me. Okay, this is my tie, and he has never returned it yet. So 6 years, and I'm still waiting. So I have hopes. So case number one, I'm presenting a 45-year-old female, past medical history and past ocular history, pretty much unremarkable. She, as you can see, has a very high correction, pretty much only like just a little bit of cylinder, but mostly mild, minus in the cycloplegic refraction, minus 9.25 and then minus 8.5 in the left eye with a little bit of seal there. Not a lot of changes in the slit lamp or in the fundoscopy. IOP was normal in both eyes, no major changes. And the right eye, as you can see here in the Pentacam, nothing major that like catches the eye. Pretty unremarkable Pentacam, I would say. With the rule of astigmatism, just a little bit, 0.8. Cornea rather like on the thinner side, like 524, but elevation maps look good. Similar picture for the left eye with a 517 cornea, also on the thinner side. And the Bell and Ambrosio display showing a D-score of 0.57 in the right eye and 1.09 in the left eye. Again, nothing really striking here. And this is a side-by-side comparison of the right and left eye. As you guys can see, very, very similar topography and pachymetry maps in both eyes. So for her, the options that we had, of course, are pretty much all we have available right now in terms of refractive correction. So she's like a 45-year-old female, so pretty young for refractive lens exchange. So we already didn't even offer that to her, to be honest. So we took that out of the equation. And then if you think about like PRK or SMILE for her, PRK, we thought that it would be too much of a high, like a correction that would be too high for us to show good results in terms of long-term stability, given the fact that it would be a higher risk of regression a little bit, and also the risk of haze, although even with mitomycin that risk is small. But we didn't want to do that, and she also didn't want PRK as well. And when we offered SMILE for her, even though the cornea was a little bit thin, she also wasn't very keen on it because she never heard of it. So there was this kind of like reluctance on, I don't want to do that. And LASIK, so SMILE, when we offered SMILE to her, she wasn't very keen on it. So we decided not to do that because she really didn't want to. So she came here very decided on having LASIK. And this is something that, keep in mind, I always like to stress that whenever I'm talking to international people, here in the US, it's a little bit different compared to Brazil and maybe I would say most countries in South America, in a way that like the patient has a say a lot more on their treatment. Like I feel like that, and correct if I'm wrong, please do correct me if I'm wrong, but I feel like in Brazil, by the time I was there, like the patients would kind of like, you are the doctor, do as you say because you know everything. And here, like, it's more like an open discussion. If the patient really wants something, they will kind of like, okay, it's I understand what you're saying, but it's like a joint decision. So I feel this is more practiced here in the US compared to Brazil. But again, please correct if my perception is wrong. So when we offered an ICL to her, which I believe would be a great option given her correction, pretty much only spheric correction, so high chances of a great result. Cost was an issue. ICL costs pretty much here in the US double the price of LASIK, and she was really like taken aback by it and said like, maybe I'm not ready for it. So cost was a problem in this case, and then LASIK was left as the only option. And let me talk to her about it and talk to her about the risks of ectasia, especially. and the thin cornea, what would cause, she said like, well, if you don't do it here, I may go ahead and do it somewhere else because I really don't want to wear glasses anymore. And then you're like in that decision, well, what do we do? So like, can you go to like another place and not trust the doctor? And what are we gonna do? You know, like, so it's kind of one of those decisions. So she was really gonna have LASIK somewhere else. So, okay, we decided to do ourselves LASIK here. And we actually had a discussion with her about monovision as well. She's a 45-year-old female, so she would need near glasses for near. And we tried contact lenses for simulating monovision for her in both eyes, and she really didn't like it. And I think it was the left eye that was the dominant eye when we tested in clinic. But yeah. So this is the operative report, and we used this laser here, the Technolastinel, which is a newer laser here in the US. They're doing the FDA trials for it, and she was actually part of this trial, to be very clear. So she was part of this trial, and that's the reason why we wouldn't actually change the optical zone, because for the trial you had to use the standard, let's say, features of the laser. You couldn't change a lot here. So we had a max ablation of 172 microns with a flap of 100 microns. So if you look at the PTA, was around 50% in both eyes, which we all know it's a lot. And residual stroma bed was about like 250. So still above what the literature says, which is good. But again, the PTA is pretty high. So this is the post-op map for her. So pretty good ablation. As I said, like 350, 360 microns of thinnest pachymetry map. So if you discount the flap about 100 microns here, you're around at that 250 to 60 range for residual stroma bed. And a happy patient. She's 2015 plus 2 OU. So happy patient, at least for now. And this is 1 month post-op, by the way, so 2015 OU. So, of course, I think the striking thing about this case is the high risk of ectasia, given the amount of ablation and corneal changes that we promoted. This is the classic random and ectasia score, ectasia risk scoring system. And as you can see, she kind of like falls within the 1 point given her correction, and 2 to 3 points depending on the eye regarding the residual stroma bed. So somewhere between like borderline risk to even like a high risk, depending on the eye. However, we also know that the two most important variables in this scale is the topography pattern and the age. And she was well above 30 years old. She's a 45-year-old, and she had a pretty normal Pentacam tomography. So when we look at the role of PTA after LASIK in eyes with suspicious topography, we know that the PTA, a low PTA basically means a low risk of ectasia. And even patients with a normal topo with too much of a high PTA can have a higher risk of ectasia. So that's the work that Marconi has been like advocating for the last several years, that a target of, in general, especially in a patient with a normal topography, the target of PTA is less than 40%. And in patients with a higher suspicion for keratoconus, so not an entirely normal cornea, even if you're going ahead and doing surgery, you should probably go even lower than that. However, there have been papers in the literature showing that PTA may not be as good as most people think. And this is an example, like a paper that was published by Cornea Chan and the Deming Gatnell group in 2018, kind of like questioning a little bit the value of PTA. And just to be fair, this paper didn't use the PTA as it is completely advocated by and how it was described by Marconi. For instance, they used the Orbiscan instead of the Pentacam to analyze, and we know that Orbiscan is probably not as good as the Pentacam. And there are a few other nuances about this paper that are a little bit questionable, but it's been published in a prestigious journal, and it's there for you to analyze. And this is unpublished data that Dr. Krueger got from Steve Schauhorn, should be published very soon, on a database of 300 plus 300,000 eyes, and about 200 eyes of those 300,000 got ectasia. And the most important risk factor, as we all would expect, was the presence of formed fruit keratoconus, so a abnormal topography. And age was also big. And the combination of those two indices, so like asymmetry indices with age, had a very high odds ratio as well. And he didn't find in his database any correlation with PTA. And one thing that he did find is that all eyes respected the minimum 250 residuals from a bed. So again, this is another view of PTA as something that Marconi himself said in a review paper that he published. I guess this is from 2017, 19, if I'm not mistaken. It should be clear that PTA is not a screening method, but actually a robust risk factor. So there will be eyes with high PTA that will never develop ectasia, but it's a risk, right? You can just like, and I always remember Dr. Wallace Shimon, my mentor, my PhD mentor, like saying like, well, you can smoke like 3 packs of cigarettes a day and never develop lung cancer, but it's a risk. You're a higher risk than the normal population. So you kind of have to factor that in when you're offering LASIK to those patients, and if the patient is willing to do it and sign the consent. And as Dr. Shimon like noticed in the chat, the laws are a little bit different here, so kind of like makes the physician less what's the word for it? Not responsible, but well, it's escaping me. But like you are not the patient. If the patient assumes the risk along with the physician, it's not a too much of a big problem, legally speaking. So we have a 45-year-old patient with a normal topography and a residuals from a bed of 250. So that was the rationale in offering LASIK to this patient. And I'll just quickly go by 2 other different cases here, just to show how we can change our approach in different patients with similar situations. So here we have a 38-year-old male with past medical history, which was unremarkable, but with chronic dry eyes. And a higher correction as well, like not as high as the other one, but about -7 with some sill on the right eye and -8 in the left eye, and clearly had some signs of dryness, and also had a Y without pressure in the fundoscopy, but otherwise normal exam. Topography here shows like a little bit maybe more concentric bow tie, like constricted a little bit more, but still like maybe some slight skew deviation here in the right eye. And the left eye more like this like unusual pattern of like probably just dryness, but nothing that strikes in terms of ectasia. And again, Bell and Brugia display, what numbers were pretty good, -0.2 in the right, -0.3 in the left. So pretty good numbers there. And again, just a side-by-side comparison here in both eyes. So for this case, given the severe dryness, we did offer Smile to him. Just as a note of, he just came this week and he had some signs of like hypertensive retinopathy as well. So we told him, and his blood pressure was high. So we repeat his endoscopy exam, and we sent him to the go treat that hypertension first, and then we can do that. Yeah, but nothing aside from that. And so he will be a Smile patient in the near future. And this is a paper that was recently published in the Clinical Ophthalmology Journal, showing that how do we use the same principles that we think about PTA that was described for LASIK in other procedures. Because if you try to correlate what PTA means, you could apply it to like Smile and PRK as well. And this paper shows that like Smile and Smile and LASIK in this case, but it could be applied to PRK as well, alter the range of PTA within which refractive surgery could be performed with a lower risk, but we don't know what number that is yet. We probably need to study a little bit more. We know that Smile biomechanically, the biomechanical results of Smile is a little bit different than LASIK, so probably not as much as we think, but still different. So we need to address. This is something that we need to think about as well. So And then a third case here, a much higher correction, pretty normal, a 30-year-old male with a -10, -11.5 in the right and the left eye, normal. And then you see the topography again, 530, so it's not super thick. And then there's like asymmetric bow tie here, not super asymmetric, but still like a good a higher curvature in the right eye here. In the left eye, very similar pattern. Maybe even like a little bit of like a dislocation here in this thinnest point in the pachymetry map. So inferiorly, so nothing major in the belly ambrosial display, but still not the prettiest cornea you want when you're thinking about ablating a -10 patient. So in this case, we offered an ICL, and the patient was actually like, that was the only option we offered her, and he was okay with that and understood the risks of LASIK in this case, and he was fine with the cost and everything. So he's going to have an ICL, I think, in a couple of weeks. So those are the three cases that I had to present. I don't know, Dr. Krueger is not in the room here with me. I think he's on Zoom. So if he wants to comment, and if anybody else has any other questions or comments, please go ahead and feel free to talk. Thanks.
Thank you, Vinicius. Do you have any questions or comments from our attendees?
I may try to comment, although my internet connection is really extremely unstable. Can you hear me?
Yes, we can hear you.
Okay, I'm using my iPhone, my cell phone. So the only comment that I would, because this Schauhorn data, as far as I know, hasn't been published. Is that correct?
Yeah, it is correct. It hasn't been published yet.
Has not, right?
Yeah, no.
Yeah, because when he says there's no really relation or correlation with the PTA, again, it shouldn't be a correlation.
I know.
This is because PTA is a risk factor. It's not a screening exam. But anyhow, and when you consider age as something related to time, this may be not an odds ratio, but it just says that the age makes the ectasia to appear earlier. So maybe age may not play a role on it. And about the last case that you proposed, ICL, I think you're very nice to the topography, because for me, this is a keratoconus. I have no question about it. And you said it's not that good, but that's okay. I think it's just a point of view. Congratulations, great talk. And I'm sorry I missed some of it, but great talk. And good seeing you all.
Awesome. Yeah, good hearing you as well. Thank you.
Any other questions or comments regarding Vinicius' cases? Also, I'd like to ask you a question. Dr. Wallace said, I don't know if I understood it correctly, but that time may play a role, but not age, right? But I thought that age in this question, and what matters to the ectasia risk score system, or it would apply as a biomechanical surrogate. Am I interpreting it correctly?
No, it's I believe I think, like, if you think about it, whenever we think about ectasia risk scores and systems, and whenever we think of age, I think it's a little bit of both, but definitely we don't have a definite answer for it, right? I mean, there is no like real study showing that the age would be more biomechanical or just a time thing. But we do know that as you age, the cornea stiffens. So if you think about it, like the same patient, the same prescription, but at different time points, like a -5 whatever patient at 20 years old and a -5 patient at 40 years old, the same patient, same genetics. We believe, again, we don't have this scientific data to assume that, but based on what we know, we believe that this cornea will react differently. And if you do surgery in those two different time points, if you were able to do it, let's say, like one eye at 20 years old and the other eye at 40 years old, you would expect different results, because the cornea, we know that the cornea stiffens with age. So if you apply the laser and if you cut the flap at a 20-year-old cornea, that cornea is weaker than the stiffer cornea than when the patient is 40. So yes, time is important as well, but I believe that the biomechanical impact of age in the cornea is very important. Yeah. So yeah, you're not wrong. I think.
No, I agree. I agree with Vinicius. Where the point that what I'm trying to point out is just, I'm always worried when someone sees a patient with a keratoconus and assumes that since he's 40, he won't have an ectasia anymore.
Oh yeah, I agree.
Yeah. And that definitely, it's always important for us to remember that we are looking to something and trying to find out another thing. So we look for corneal deformation, but we are trying to find out corneal rigidity. So if I see a cornea that is deformed because at an early age, the cornea was very, very elastic, this cornea may or may not have achieved the rigidity that is needed to become stable and may undergo to LASIK surgery. So it's always very complicated. So what I would say is probably age is a risk factor, but it's not a protection factor, or we cannot consider it as a protection factor. But again, this happens when we look for something and try to measure another thing. Unless we are able to really measure corneal elasticity, we will keep with all those questions that will never be answered. We are trying to define the size of a person measuring the length of their hair. It's complicated.
Yep.
Great example, Dr. Walls. Thank you. If you don't mind, we may go ahead with our case.
Yeah.
So calling Ibraim. Thank you once again for your participation, Ibraim, and we'll present some rather unorthodox approaches. So I hope you don't put the blame on him. So Ibraim, please.
Okay, great. So thank you, Tagush, for the invite. It's a pleasure to be here presenting these cases with Vinícius, Dr. Stefano. As he said, we are friends since we started our residency program. And here is a more recent photo of our last meeting in San Francisco last year. He is here with his beautiful family. This boat here is not his, but it could be because Vinicius is known around here to be a very wealthy guy. That's one of the reasons why I didn't get his tie back, because it's a very expensive one. But maybe someday, Vinicius, maybe someday. So I'd like to say that I have no conflicts of interest with this material here. I'm going to present the first case that's about a 33 years old white female nurse born and raised here in São Paulo, and she wanted to reduce her spectacle and contact lenses dependence. Her history was unremarkable. Here is her refraction, her cycloplastic refraction. You can see that she was a very high myope. She didn't reach 20/20 vision, and the rest of her exam was pretty much normal. She had a wide anterior chamber and retina with only signs of mild atrophy of the retinal pigment epithelium, which is normal for a high myope. Here is the pentacam of the right eye. You can see that she has oblique astigmatism, small asymmetry, but not too much, around 3.3 of astigmatism. And here's the pachymetry map. She had a thin cornea with around 493 micra in the thinnest point. Here's the left eye, astigmatism with the rule. Small asymmetry too, but not too much. Around 2 of astigmatism, corneal astigmatism here. And the pachymetry map here shows a similar pattern with 490 in the thinnest point. Here we have the specular microscopy. You can see that she has a good pattern of cells, around 2,600 cells in each eye. We did also a Visanti of both eyes to make some measures if we decide for anterior chamber lens or posterior chamber lens. You can see that she has 3.5 of anterior chamber, which is enough for all of the intraocular lenses. Here's the biometry. She had a high axial length, which is compatible with the myopia. The anterior chamber here is a little bit different than the other one because it measures also the thickness of the cornea, but they are pretty much the same results. And the white that's also used for the calculation of ICL, for example. So she had this high myopia, the compound myopic astigmatism, and then I would like to ask what would be the management of this case.
Well, hello, good morning, Dr. Krueger. Thank you for joining us. It's an honor to have you here with us. And Dr. Vinicius, would like to say some words.
Oh yeah, so Dr. Krueger is our chairman here at the Truson Eye Institute and former director of the Cleveland Clinic Refractive Surgery Service, and highly respected and worldwide known refractive surgeon, pioneering many areas of the field. And yeah, it's a pleasure to have him as my boss, our chairman, and a pleasure to be here as a resident. And yeah, we already went through our cases here, Dr. Krueger. Of course, you know all of them. So yeah, go ahead.
So Dr. Krueger, I don't know if you were able to see Ibrahim's initial.
Yes, and tell me again the age of the patient.
He was 33 years old.
33. Okay.
Yeah.
He
has a refraction, the cycloplegic refraction. Let me pass here the pentacam.
Mm-hmm. And the cell counts were actually not too bad, right?
Yes, that's right.
Yeah. So, you know, looking at somebody like this who has a corneal thickness that's less than 500 microns and with such a high refractive error, LASIK would be out of the question, clearly. The idea of doing a PRK, although it could be considered, PRK for such a high correction may not do quite as well and flattens the cornea significantly. And in light of reasonable cell count, I think something like a toric ICL would be a reasonable option to consider for a patient like this.
Okay, great. Someone else wants to comment on this case?
I'd like to ask, why not to consider clear lens extraction? And I mean the devil's advocate here, okay?
33-year-old.
Yeah, I think the thing to say, you know, in light of many people who are very used to doing cataract surgery and could do a refractive lens exchange in a patient like this, the two biggest disadvantages to doing that is, number one, they're young enough that they're still accommodating, and you're going to take away their accommodation, which is really taking something away in the midst of trying to fix them. And then number two is because they're a high myope and they have a long axial length, they have a higher risk of retinal tears and detachments. And anybody under the age of 50 or 55 generally has a higher risk of retinal detachment than those older because of the vitreous syneresis and condensation. You get more of a vitreous detachment with age. So you're adding undue risk for a detachment and you're taking away accommodation.
Perfect. So I'm going to show what we chose. We chose the same thing. We chose a toric ICL implant in both eyes. The surgeries were done typically around 45 days between each eye. Here's a quick video only showing how the surgery is performed. As it's a toric IOL, the patient was marked. We did the paracentesis first and introduced some viscoelastics in the anterior chamber. Then we perform the incision with viscoelastic inside of the eye already to avoid touching the anterior capsule. We expand a little bit the incision. The lens is implanted over the iris, and then with the help of a manipulator, we introduce the aptics behind the iris. That's the last one from the main incision. We're checking the axis here, and then after that, we're just gonna wash out the viscoelastics from the anterior chamber. So this is the first day after the left eye surgery. Patient was already 20/40 without correction. Her IOP was a little bit higher, probably because of some residual viscoelastics in the anterior chamber. She had a little bit of corneal edema, and the valve was 0.33, 330 micron. This is the old model of the lens. I believe it was the V4B. So this model would expand after the surgery. And here it was 30 days after the surgery. The vault was 710 micron, which is still acceptable. The IOP was a little bit better, and the uncorrected visual acuity was 20/20. Residual refraction was 0.25. Here's a photo of showing the vault, the distance between the crystalline and the ICL. This is the right eye. The first day the patient had a transparent cornea already. The vault was a little bit smaller, around 300, and 30 days after it was around 530 micron. There was a residual astigmatism in this one because she had around 3 diopters, and so there was this residual, but the patient didn't complain. She was happy, and we were happy too. We decided not to do anything else. She was 20/25 with 20/20 with both eyes open. So I'm gonna move on to the next case now. Okay, so the second case is about a 25-year-old male white artist from São Paulo who also wants to reduce his spectacle dependency. He was also a high myope. Here it is the cycloplegic refraction. And this patient would reach 20/20 with his spectacles. The rest of his exam was unremarkable. Here's the pentacam. I expand here the results of the exam so it's easier for you to see, but you can see that he has almost oblique astigmatism here, pretty much symmetrical. And this patient also have a thin cornea here with the thinnest point with 476 micron. The belly ambrosial was unremarkable, and the curve of the thickness of the cornea was also unremarkable. This is the left eye, very similar to the right one. Regular symmetrical astigmatism, thin cornea too. Unremarkable in the belly ambrosial and the curve of corneal thickness. So the patient was similar with the last one, compound myopic astigmatism, thin cornea, high myopia. So what would be the options for this patient?
Cross-linking?
Do you think he has a keratoconus here?
I mean, no, the topo like is not necessarily like, it's a highly toric cornea, but it's kind of like a very aspheric cornea, as we would say, right? And
That's true.
The pachymetry is very thin. So one thing, like, I don't think even PRK in this case would be warranted, to be honest. Like, it would be a little bit of like a too bold of a procedure, in my opinion.
Yeah, if I could jump in on something like this. So what Vinicius is sort of referring to is that there seems to be this truncated bow tie pattern that looks like it's a little bit steeper in the center. And even though all the metrics show that it's normal, you look at that and wonder, you know, could this be a cornea that's predisposed to something like ectasia? Hard to say. You know, there's no hard signs there. I wouldn't recommend cross-linking for someone that hasn't necessarily showed lots of progression or worsening. You know, you can obviously just correct the refractive error, but he's kind of getting at the idea that maybe a non-laser procedure would be better.
Yeah, I was more like playing around, but yeah, I wouldn't offer cross-linking at this time, of course. But I would definitely follow. I something that I would do. I would, regardless of, even if you're highly motivated for surgery, I wouldn't offer anything right away. I would probably like come back in 6 months or so. Let me repeat that topo, see if there is any progression or something like this, if there is any changes. Maybe even a year, maybe a couple of repeat topos over time, just to make sure everything is stable. But yeah, of course, I mean, just with at this time, I wouldn't offer cross-linking, just playing around.
Okay, great. So I'll show you what we did. This is not like our current management of cases like this. Probably we wouldn't do anything in a patient like this. We would not do a surgery with him. But there is a protocol here, a research protocol that's done by Dr. Pablo Rodriguez, in which he takes this case that we would not perform usual PRK or LASIK, and he will do a intrastromal corneal ring segment, and then do a PRK in the residual refraction. So it's a Ferrara ring. It's like our intact here. It's Ferrara, and it's a 6 millimeter segment with 400 micro thickness. And here's a quick video also of the surgery. He's marking the points for the implant of the Ferrara ring. It's done with femtolaser, with femtosecond laser. So this is the patient 6 months after the implant of the ring. You can see that there was an applanation of the periphery, but not so much in the center of the cornea. Here's our comparative before the surgery and after the surgery, and here you can see that mostly the periphery of the cornea was more plano. Here's the left eye. We did the same thing. So same pattern of flattening of the periphery of the cornea. Just showing the comparative exam. And so this was the refraction of 6 months after the surgery. The patient still had a lot of myopia here. And so Dr. Pablo performed a PRK with an EX500 wavefront optimized with a smaller optical zone of 5 millimeters and a transition zone of 2 millimeters. And she set the correction for 0.88 of the residual refraction because there is a tendency of overcorrecting in these cases. So here just showing the part of the PRK. So regular PRK with only the ring. And of course, we use the mitomycin too. So this is comparing pulse ring with pulse PRK. Okay, so you can see that the PRK flatten a lot the central part of the cornea. And here is comparing all the treatments with the final result. You can see that all the cornea was flattened. Same thing here with the left eye. Pulse ring compared with pulse PRK, flattening only of the central part of the cornea. And here, pre all treatments, after post all treatments. You can see the flattening of all parts of the cornea. And so 60 days after the surgery, the patient has a little hyperopia, not too much, and was 20/25. Happy with the results too. So this one is the most controversial one. I would like to emphasize that that's not our regular practice here, but it's an interesting case in the research protocol, and I want to have some discussion with you. I think Dr. Walls would like to comment on this if he was able to watch it.
Not really.
Dr. Krueger, would you like to?
I have to say, what's interesting about this case as I look at it is traditionally when you look at intracorneal rings, it's the idea of filling the stroma with a space or a substance that then stretches the cornea, which then flattens it. And yet when you look at this, there was an element of flattening, but the very center was also steeper too. That sort of gave you the advantage that when you did a PRK on top of that to further flatten it, that steeper area in the center also became flatter, and maybe there was less spherical aberrations, or secondary spherical aberrations that were created because of this, just because that central steepening was then further flattened. So it kind of worked out well, the two combinations, to get a more uniform final surface that wasn't excessively flat. I think it's very intriguing. It sort of also gives you the idea that if this case ever did have more of a predisposition to developing ataxia, the rings would stop some of that from happening, because it, again, stretches the cornea and provides almost like a girdle to hold the cornea in shape.
Thank you. Yeah, this is a more simple case. It's a 34-year-old male white software developer from Rio. He wanted to reduce his spectacle dependency too. This patient is hyperop. He is his manifest refraction and the cycloplastic refraction. You can see that it's pretty much the same thing. And the rest of his exam was normal. Here I only have a Galilei exam. Sorry, I don't have in higher definition, but you can see that he has a regular astigmatism here, oblique astigmatism. Here are the results of the keratometry, pachymetry. You can see that this patient here has a lot of cornea, but he also had a small anterior chamber, which is expected in cases like this. Here's the left eye, similar to the other one, also a thick cornea and a small anterior chamber. And so then this is the discussion if we would do a ICL implant here or LASIK. So for this patient, we decided to treat it with frontal LASIK. We used the FS200 and EX500 wave light. Here's the plan of treatment for this patient. For the right eye, as expected, he will treat more the periphery of the cornea. Here for the left eye too, very similar. And on the day 30, patient had a good result. He was happy, no complaints. He was 20/20 without correction, with only a residual astigmatism in the left eye, mainly. And that was a good result. I would like to see if Dr. Krueger or Vinicius would think about anything else.
How old is the patient again, Ibrahim?
He was 35, I believe. Let me check here.
A little too soon for refractive lens exchange, I believe.
Yeah, 34 he was.
Yeah, a little too soon for that.
Yeah.
So the other option, which is not been popularized yet, but has been done in Europe by Theo Seiler and also in India in a few locations, is a like procedure. Like stands for lenticular insertion keratoplasty, or lenticular implantation keratoplasty. And the idea is that because higher hyperopes have, you're subtracting tissue by doing a LASIK procedure in them, you're creating a shape which is not the most desirable. There's higher chances of regression, more likelihood for aberrations as well. But if you could add tissue, you would get better asphericity of the final outcome. You wouldn't be subjecting it to more irregularities, as you sometimes see with a hyperopic LASIK. And technically, you could always extract the tissue at a later date if you really wanted to. It could be reversible if necessary. So Professor Seiler had actually come up with this idea of making a large LASIK flap, something larger than 9 millimeters, more like 10. In this case, it might have been hard to do that because it's a smaller cornea, a smaller eye. But then under that flap is adding tissue that's been pre-cut according to the refractive profile. And he typically adds tissue that's slightly more than the refractive error to take care of even an element of tonus, as he calls it, or accommodation that usually is in a patient with hyperopia. Even when you do a cycloplegic refraction, they often have a little extra need for tissue. And then the idea is that after you do that, if you slightly overcorrect them, you can always lift the flap and do an enhancement and get them exactly where they need to be. And they have much more of a aspherically appropriate cornea at the end. There are other tissue addition, like in a smile pocket procedures, that could be considered. And I think this is an area of the future that we might see if we can get access to the tissue and we find that there's no rejection or any other potential complications from the use of tissue.
Thank you. Yeah, that's very interesting. Yeah, could be an option here. So I would like to thank everybody, Dr. Krueger, Dr. Vinicius, Taguchi, Dr. Bernardo, and Dr. Paulo for helping me with these cases. And thank you. I hope I can see you soon, Vinicius, after this COVID thing is over.
Right.
Me too, man.
Thank you, everybody. And I apologize for being a little late in coming on. In fact, on that first case, probably the big controversy was on doing a LASIK on a patient that had such a high level of myopia and a residual stromal bed that was kind of thinner. But it is intriguing looking at just studies going forward and the metrics that we're looking at, that focus more on corneal shape and age than maybe even residual stromal thickness to some extent. And respecting the older standards of 250, although it seems that there are better ways with PTA, can still work in an older eye.
Dr. Krueger, here's Fabio Casanova from Recife. It was a pleasure to see you again.
Yes, good to see you too.
What do you think about the toric SL implant for the second case? Because we discussed about the keratoconus, hypothesis, or thin cornea. But I think it's a good case for the...
Yeah, I would have thought that might have been another good case for a toric ICL. And I don't know how often you do ICLs in Brazil. I mean, in the US, it's still less than 1% of all refractive procedures. It's relatively small compared to laser. But in China, they're doing ICLs about 10% of all the refractive cases, which is a lot. I mean, it's a big market in China, and they have a lot of higher myopes, so that's part of the reason why. But I've actually watched a surgeon there do a 2-minute ICL, no viscoelastic, which I was stunned by seeing that, you know. So they have really adapted themselves and made ICL a very streamlined, easier procedure to do. And I think that might be something we'll see in the future as well.
Yes, here in Brazil, we have the same, less than 1% for refractive procedures. But I think it's a good option.
Yeah, I would think that if you presented a case like that second one in China, they would have never considered anything but an ICL.
Yes. Okay, thank you.
Yep, thank you. Good to see you.
Good to see you again.
Great. So I'd like to once again thank for the participation of Nebraska colleagues, and especially Dr. Ron Krueger. It's an honor to have you here again. And I hope these meetings are more recurrent, and as Ibraim said, maybe sometime ahead we can plan on meeting personally, right? So thanks once again for our attendees as well. And on the next week, we're going back to the topics of cataract surgery, and I'll leave to our guests to make their final remarks as well. So feel free, Dr. Vinicius and Dr. Krueger, please.
Just thanking everyone again. It's just so you know, like I every now and then I log into your YouTube channel and I watch like the meetings. You guys like did a great job. Like the level of the meeting is really like, as some soccer players would say, like outro patamar. Like you guys like have pushed it like to another level. Like it's really great. And I'm proud of what you guys are doing, and it's a pleasure to like talk to you. And I also hope that we can extend this partnership in the future and do it like joint meeting together in person when this COVID thing is under control.
Yeah, and I would like to just comment and again thank Dr. Shimon for sort of being sort of the senior representative to get everybody motivated on some of this, as well as Dr. Tagashi. And I'm excited by the relationship we can continue in this way. I think it's good for both sides to be sharing and learning from each other. And as time goes on, we will make some of these visits personal if possible.
Thank you, Dr. Krueger. Thank you, everybody, and also thanks, Ken, for the support. Many times not mentioned before. So have a nice week and a nice weekend, everyone, and see you soon.
Okay, thank you very much.
Bye, Ron.
Bye, Wallacey. Good to see you.
Good to see you too.